We're now talking about section 6 of chapter 11 on muscles of the axial and appendicular skeleton. We're now covering the muscles of the abdominal wall. We should be able to, after completing this section, list the 4 pairs of abdominal muscles, compare the actions of the rectus abdominis muscle with the oblique muscles and the transverse abdominis. For the muscles of the abdominal wall, those muscles compress and hold the abdominal organs in place. They flex and stabilize the vertebral column. The external oblique is located superficially, closer to the surface. Its fibers are directed inferior-medially. They form the aponeurosis anteriorly, and that becomes the inguinal ligament inferiorly. The internal oblique is located deep to the external oblique. The fibers project superior-medially, and they form the aponeurosis anteriorly. So they kind of go on diagonals across one another. The transverse abdominis is the deepest of the abdominal muscles. Its fibers project transversely. It forms the aponeurosis anteriorly. It plays the greatest role with the basic stabilization of that lower region there, that thoracic and lumbar spinal region with the pelvis too. Basic stability. It plays a primary role, not the only muscle playing a role, but the primary role. The rectus abdominis has an anterior medial location. Its fibers run vertically. It's partitioned into 4 segments by fibrous tendinous intersections. It's enclosed within the fibrous sleeve, the rectus sheath. It's formed from the aponeuroses of the external and internal oblique, the transverse abdominis. In its rectus sheath, the 2 sides are connected by the fibrous strip linea alba. Its primary job is to flex the spine, primarily. It plays a role in some stability, but it would not be referred to as a primary stabilizer, except for the fact that obviously when one muscle pulls one way, there's at least one muscle on the other side of the body pulling in the other direction, and when they both do their job from an isometric standpoint, then they're involved in stability to some extent. But transverse abdominis would be your primary recognition for stability. And ironically, people often try to target the rectus abdominis to get those washboard abs. The reality is that those muscles themselves don't give you the abs that you see. They give you the hypertrophy, to be really clear. You won't see anything if you're thin unless you have hypertrophy of rectus abdominis. But if you want to be able to see the rectus abdominis below the thickness of the external layers, you have to obviously be lean enough to be able to see them. So it's a combination of 2 things. When people say they want to be able to see their abs, well, you got to be lean enough to see them, and you have to have enough hypertrophy of your rectus abdominis, or there'll be nothing to see either way. From the anterior view here of our abdominal muscle type regions here, we have our superficial. Pectoralis major is actually referred to more in general. They call it the abdominal wall. It's questionable if it's really a part of the abdominal wall, but it's really above the region of the abdominal area. Serratus anterior as well. But then you have our tendinous intersections here between the rectus abdominis muscles. And here's our rectus sheath, okay, that white layer here. And our umbilicus, basically your belly button, right? Linea alba here, and the aponeurosis of the external oblique. And the rectus abdominis, I'm sorry, I already said that. Transverse abdominis is below here, more deep. The internal oblique here, the external oblique here. So you see external oblique here, and then internal oblique below it going this direction. And of course, here's the inguinal ligament. As far as the muscles of the abdominal wall, unilateral contraction of the oblique muscles and the transverse abdominis helps laterally flex the vertebral column. And the transverse abdominis honestly is not playing a primary role. It's more of an assistant, more of a synergist. The primary role is coming more from the obliques for getting lateral flexion to some extent, but even still, even more so for lateral flexion, the obliques are not really playing a primary role either. The fact of the matter is for lateral flexion, there are numerous muscles playing a role, and they are by no means the biggest player. They're one of many, many players. It's like having a group of 10 or so people, give or take, playing a role in a job, and then saying that one muscle does it. It's actually multiple muscles play a role with the lateral flexion of the spine. Including the quadratus lumborum and the erector spinae, and multiple muscles within that erector spinae. And of course, they also help rotate it toward the opposite for contraction. The primary role, the primary mover, or primary job, I should say, of the obliques is rotation. It is rotation, and assisting more with the flexion component, honestly, more so than lateral flexion, even though they can perform that function to some extent. Let's take a look at our anatomy here a little more closely here. So you can see more from an actual cadaver here, or the tendinous intersections here, though, between our rectus abdominis, basically little sections. And again, a rectus abdominis here, right? Here's our rectus sheath, more superficially. The umbilicus, so once again, our belly button, or linea alba Here, that line there, separating that rectus sheath from our rectus abdominis here. The aponeurosis of the external oblique. Okay, and of course, they're going to get into, there's our external oblique here, that's cut, going this direction here, travels some medial, going more to the outside and upward, more superiorly, right? And then we have here the transverse abdominis, deeper layer here again, and then an internal oblique, going a little bit more crosswise and traveling more the opposite direction, not opposite direction, but a little more so, I'm sorry, that being the internal oblique here, going opposite diagonal path than the external oblique, and this being transverse abdominis, the deepest layer there. And here we have the external intercostal here and the internal intercostals. And of course our inguinal ligament once again here. Closer look here, this inguinal ligament along here. Plays a huge role for helping maintain stability there, the pelvic region there and the abdominal wall. For hernias, there's a portion of the viscera of the tissues that basically are the organs that protrude to the weak point of the abdominal wall. An inguinal hernia is when the loop of the small intestine protrudes through the superficial inguinal ring, obviously causing significant pain. It's more likely to occur in males since their inguinal canals are larger to accommodate the spermatic cord. So it's much more likely to occur for a male. High abdominal pressure, like straining to lift something heavy, can push the intestine into the canal. Not a pleasant sounding concept, is it? Physicians test for it by palpating the inguinal ring while patient coughs, and the cough raises abdominal pressure. And it's actually a lot of people have an inguinal hernia and just don't know it, because like every injury or problem or disorder, disease, issue, challenge, you name it, there's always levels. It's not just something happens and therefore it means this. There's always variability in terms of the level of symptoms, a level of a problem versus it being a problem or having symptoms at all. So for this section with the abdominal wall, you should be able to simply answer what are the main actions of the abdominal muscles and their generalities for each basic function. And then we're going to talk about the muscles of the pelvic floor. Here we should be able to describe the functions of the pelvic floor muscles and identify the boundaries of the perineum or perineum. The pelvic floor is formed by 3 layers of muscles and fascia. And it really should be fascia IA typically. The E is not typically used in most situations here. Collectively known as the pelvic diaphragm, and it supports the pelvic viscera, all the organs there. Let's take a closer look here. So we have here our ilium, we have our coccyx, we have our ischial spine, bone here, obturator internus, our anal canal, vagina for the female, urethra, urogenital diaphragm, our pubic symphysis, cartilaginous connection there, the sacrum, right? The sacroiliac articulation. We're looking at again for the superior from above here for the female here. The piriformis. Too much is made for a lot of people from an athletic standpoint about piriformis being an end-all be-all muscle, which we'll talk about when we get more to muscles of the hip and the lower region specifically. Coccygeus, basically here, our iliococcygeus, and then we have our pubococcygeus here, and the obturator canal once again here. Okay. The perineum is a diamond-shaped region between the lower appendages. It's bounded by the pubic symphysis, the coccyx, and ischial tuberosities. It contains 2 triangles that are divided by the transverse line between the ischial tuberosities. The urogenital triangle contains external genitalia and the urethra, and the anal triangle contains the anus. So we have our urogenital triangle here, and then we have this guy here. Then we have our raphe or raphe, basically our bulbospongiosis, the ischiocavernosus here, and our superficial transverse perineal muscle, levator ani or levator ani, the gluteus maximus, the anal triangle, and of course a perineal body here. That's basically the male for the inferior view. Here's the female for the inferior view, the urethra, the vagina, the bulbospongiosis, and the ischiocavernosus, the perineal or superficial transverse perineal muscle. And we have our anal triangle here, and this being our urogenital triangle here, and the perineal body once again, levator ani or ani, and then the gluteus maximus. So you should now note what are the functions of the pelvic floor muscles. And we're going to stop with this section here because up next we have a more broader section and talking about the pectoral girdle and the upper limb.